So today we are going to talk about rheumatoid arthritis from my book The Resident Physician. So let us first do introduction of rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disease which is more common in female. Common age is 30 years to 50 years. It is associated with HLA-DR4, Sjogren syndrome, Filty syndrome, SLE, and systemic sclerosis. Okay, so this is just a short introduction about rheumatoid arthritis. Now let us talk about the clinical features. Now in the clinical feature, the patient having bilateral symmetrical arthritis with pain, swelling and stiffness in small joint of hand, feet and wrist. There will be morning stiffness which will be more than 1 hour and which will be improved with activities. There will be no involvement of distal interphalangeal joint, and wrist is the most common joint which is involved. So these are the proximal interphalangeal joint and this is distal interphalangeal joint. The distal interphalangeal joint is not involved in rheumatoid arthritis. The other thing, there will be morning stiffness which is more than 1 hour and which will be improved with activities. There will be symmetrical involvement of joint. R effector will be positive. Anti-CCP, if it is positive, then it is called seropositive rheumatoid arthritis. If it is negative, that is called seronegative rheumatoid arthritis. ESR and CRP will be raised. So now on examination, we will notice the vitals and then, we will do examination of the hand. There will be swelling, there will be pain, there will be tenderness, and there will be rheumatoid nodule, subcutaneous nodule or extensor surface, and there can be deformities if it is not treated on the time. These are the extra-articular manifestation of rheumatoid arthritis. These are subcutaneous nodule which is present on extensor surface. If the patient is not treated on time, then the patient will also having joint deformities. Investigation, we will do CBC, which is complete blood count. The patient having autoimmune disease will be normocytic normochromic anemia. We will also do ESR, CRP, which are acute page reactant, both will be raised. Then we also do rheumatoid factor, R effector, which is positive in many of the rheumatoid arthritis patient. Then we will do anti-citrulinated cyclic peptide antibody, anti-CCP, which is a diagnostic test for rheumatoid arthritis, and specificity 90% and sensitivity 60%. We will also do BSR, RFTs, LFTs, ECG, urine, RE and X-ray of the affected joint. We check serum anti-CCP of a patient which has come out more than 200, and the normal value is less than 4, and the patient having more than 200, it means the patient having seropositive rheumatoid arthritis. If you check here, then we can diagnose easily. First of all, we will look the joint distribution, which we will give the numbers, and then we will check the serology. Negative RF and negative anti-CCP, the score will be 0. If low positive, I means you just check it and compare it with the patient, and you will see if the score is more than equal 6 or more than 6, then the patient having definitive rheumatoid arthritis. The 4 prognostic features of rheumatoid arthritis: RF positive, anti-CCP positive, HLA-DR4, early articular erosions and CDS onset, and female like this, female patient. So these are the 4 prognostic features of rheumatoid arthritis. Now let us talk about the treatment of rheumatoid arthritis. So if the patient came with acute pain, then we can give a steroid or injectable, which is not in the book, but most of the physician advise this injection state once. Injection methylprednisolone acetate, which is came under the brand name Depomedrol, 40 mg and 80 mg. Together it will become 120 mg, and we will give IM state once. If you see here, this is the Depomedrol injection, which is methylprednisolone acetate, 40 mg plus 80 mg IM state once. ठीक है, Depomedrol इंजेक्शन हम 40 और 80 mg को मिला के दोनों को मिला के गोश में लगाना है सिर्फ एक दफ़ा. So first of all, we will give the steroid coverage to the patient, like injection methylprednisolone acetate, and this one like prednisolone 5 mg. So if you see here, we will also give the steroid to the patient, delta cortil 5 mg, 3 plus 3 for 1 week, and then 2 plus 2 for another week, and then 1 plus 1 for another week. I mean, we will give it in the tapering dose. Okay, so when we give steroid in tablet form and also in injectable form. Now the second thing, which should we give the DMARD, which is called disease modifying anti-rheumatic drugs, which we can call DMARD. The DMARD drugs are hydroxychloroquine, leflunomide, methotrexate and sulfasalazine. Here I can show you the two, cytotrexate and then hydroxychloroquine acetate. Methotrexate. Okay, this is methotrexate. Here I am having a 10 mg tablet, but we will start with 2.5 mg. We will give the 3 tablet once in a week. I mean like in Friday or Sunday, whatever, choose one day so that it can be easy per patient. We will say 2.5 mg, 3 tablet once in a week on Friday. Okay, like the demand you guys can see here. This is the cytotrexate 2.5, 3 गोली जुम्मा के दिन, हफ्ते में एक दफ़ा. और here you guys can see methotrexate 10 mg, एक गोली हफ्ते में एक दफ़ा जुम्मे के दिन. ठीक है. So when we give the DMARD drug, we will start from the low dose of the methotrexate, and then if the disease progress we can increase the dose, and then we can also add hydroxychloroquine, or we can also add leflunomide, which is come under the brand name Cara Lefora 20 mg OD. Okay, now so we give the DMARD and then we give the steroid, and now we will give the painkiller coverage to the patient. So we can give Tonoplex P or Celbix 100 mg. We can give Tramadol SOS, and we can also give Celbix Celecoxib, which is stomach friendly. So we will advise 200 mg OD or 100 mg BD, or you can add any painkiller. So DMARD, steroid, painkiller. Now if you are giving the steroid or painkiller, then you must give the PPI coverage to the patient. So in proton pump inhibitor we can omeprazole, esomeprazole, or any PPI you can add. Okay, so like you can see here, this is dipomedrol injection, methotrexate, but in this patient we also add HCQ 200 mg because the disease was progressing and it was not controlled with methotrexate, so we also add HCQ, and we can give Contour, and then we can give Celbix. So this is the full treatment of rheumatoid arthritis. But now here we should also give the patient some bone coverage so that the patient can having a strong bone. For that we can add calcium D, which is vitamins, calcium carbonate, vitamin D3, or we can add Intec D, which is Ocean mineral complex plus vitamin D. This tablet will be 1 OD 8 week. Okay, ये भी 1 week हमें देना है. अब जब भी हम मेथोट्रेक्सेट टैबलेट देते हैं तो ये फोलिक एसिड की कमी डिफिशिएंसी लाती है, तो इसलिए इस पेशेंट को हम फोलिक एसिड भी डेली देंगे. ये पेशेंट फोलिक एसिड लेगा हर दिन, सिर्फ उस दिन नहीं लेगा जिस दिन ये मेथोट्रेक्सेट लेता हूँ. ठीक है, तो इसलिए हमने लिखा है यहाँ पे फोलिक एसिड 5 mg टेबलेट 1 टेबलेट डेली एक्सेप्ट ऑन फ्राइडे. चूँकि फ्राइडे को ये पेशेंट मेथोट्रेक्सेट लेता है तो उसी दिन नहीं लेगा, बाकी दिन पूरा हफ्ता फोलिक एसिड 5 mg 1 टेबलेट रोज़ाना लेगा. ठीक है. सो we give to the patient DMARD, steroid, painkiller and PPI. This is how the treatment will be easy. You should add 1 DMARD, steroid, you should add painkiller, and you should add PPI. Okay, this is how the treatment could become very easy for you. Now we also give the bony coverage to the patient. Now many patients with rheumatoid arthritis, they are having dry eye or the tear production become decreased. So that's why we have to give some coverage to the eye so that the patient can be protected from conjunctivitis. So we can give fresh eye drop, fully vinyl alcohol, or we can give tear plus eye drop, which is a natural tear. 3 drop TDS में हम देंगे ये भी साथ में. ठीक है. So this is all about the treatment of rheumatoid arthritis. Use this chart for diagnosis of rheumatoid arthritis. This is about DMARD, and the new modality of treatment for rheumatoid arthritis. We can give injection rituximab. I already uploaded a video on injection rituximab on my YouTube channel.